Welcome to the Recovery.com podcast. Join us as we navigate the nuances of recovery, featuring heartfelt stories, expert insights, and the latest breakthroughs in mental health and healing. Whether you're taking the first step or continuing your recovery journey, we're here and hope to support, inform, and inspire you. I'm your host, Editor-in-Chief at Recovery.com, Dr. Mala Chaudhry-Malgeri. I'm joined by fellow host and Chief Growth Officer at Recovery.com, Cliff McDonald. In today's episode of the Recovery.com podcast, we were joined by Dr. Jasleen Chhatwal, a distinguished psychiatrist specializing in addiction and integrative medicine. Dr. Chhatwal is deeply committed to mental health advocacy and champions a naturalistic approach to healing, emphasizing the body's capacity to heal itself in nurturing environments. I'm excited to share this episode with you today, where she shares insights from her extensive experiences and diverse background, discussing her holistic approaches to mental health care. I'm so honored to have you on with us today and excited to talk to you. So welcome.
Thank you so much, Mala. How are you today?
Good. Thank you for asking.
Yeah.
So we'll jump right in. What inspired you to work in the field of medicine and mental health as well as wellness, and why is it important to you?
That is a long loaded question, which I think will make me give you my entire life history. I do feel like everything in my life growing up sort of led to that moment. And people who knew me when I was younger, and especially my parents, heard me often talk about all kinds of things I wanted to do. I am the Jill of all trades, where I would play different sports and be interested in different things. And every year it was a different profession I wanted to be a part of. But one of the things that's really been a thread that weaves through my life is this focus on social inequity and really wanting people to get sort of the best opportunity. And sometimes I try to reflect on where that came to be. But I think right as a child, I always wanted to educate people on sort of what was important for them. I think tried to do some like educational campaigns that were really big in India, but then started to notice how health and a person's health and the way they are really gets impacted in how they can show up for their families or be in the world. And so I think when I was about 15 or 16 in India, you have to start deciding what you're going into. I thought, well, I think I want to become a doctor, because if nothing else, whether somebody is a good person or not, you got to just give them good health and they're able to function better. Prior to that, I wanted to be an attorney, and that made me really torn, because I was like, well, what if they're bad people?
Right.
Then what will I do? So I think as a 15-year-old, that was the direction that made me think about medicine. But finally, mental health was a more winding journey. I had thought I was going to be a surgeon or an ER physician because I liked the pace of that work. And after medical school, as I started working in an ER, I actually realized that a lot of people who came into the ER were struggling with mental health conditions. And I didn't know enough about mental health from just having completed medical school. And in India, we did a 2 to 4 week rotation. There's still quite a bit of stigma. And so it was hard to really know the breadth of the work that could be done. And I started noticing that people who were repeatedly coming to the ER often needed psychiatric support. And when I would refer them to a psychiatrist, because of the amount of stigma, self-stigma and cultural stigma there was associated with mental health conditions, they would say, well, I'm not crazy, I don't need to go there. Or they'd go and say, well, the doctor gave me 6 medications. I can't be on so many medications. I feel tired, I feel doped up, I don't feel like I'm actually functioning. And I found myself naturally gravitating to trying to explain their health condition or talk to them about psychosocial stressors. And I used to do that with women in OB prior to that. And so other doctors had started noticing, they're like, you spend more time with your patients than others, or your patients are repeatedly coming back to you. And so I started to then contemplate psychiatry because I was also preparing to come to the US and studying it. And then I have some personal family experience with mental health that I can share more about later that I think was scary, but sort of poured into that interest.
Right. I mean,
Yeah.
that is such a great story. I relate to a little bit of that too. I had that compulsion to wanting to sit with people and learn about them and learn about their stories. So that is what pulled me in that direction of mental health as well.
Yeah, and I would say I think when I worked in the ER, I didn't quite have the concept of complex trauma. I don't think like I even really thought of it as trauma. I think for me, it was more like I was seeing people who had such challenges in their lives, and maybe that was the word I used for myself, was that, oh my gosh, this person has so many challenges that have come up in their life, whether that was domestic violence or sometimes sexual trauma, which were again things that were not openly talked about and still aren't in most cultures. And I was one of those people who was very sensitive, I think, to some degree, to other people's stories. And so I would try to say, help me understand, when did this start? What was going on before? And had this focus on the amount of inequity women faced in the culture. And so as I would start to unfurl some of those stories, started to realize that it was these life circumstances, that one would call them, that were starting either the presentation of mental health conditions or they were worsening them a lot. And we were seeing a lot of conversion disorders, which are things like physical manifestations of psychological distress. So people would come in where they were, the family would say, well, you know, she became unconscious, or he said now his leg could not work anymore. So no wonder they came to the ER. But if you just looked at it from a physical medicine lens, you sort of missed why they were really there. And I think for me, it started to highlight to me how little I knew. And hence, I wanted to come and train in the US. And then in training in the US, we were talking a lot about diagnoses and treatments. I was lucky that my program had a very intense psychotherapy training process. And that was something I had looked for in a program. But again, as an international graduate, you don't really get to choose as much. So I was lucky to be in that program, being at the right place. And in that program, being able to start understanding people's development, especially psychologically through the life cycle, I think is something that really helped me later on start to identify, oh, this is traumatic experiences that are either layering on or one really big traumatic experience that's leading to this presentation. So in the first year I was in practice, about 2015, 2016, I remember a young person coming to our unit, and I was working inpatient at the time, and they had a diagnosis of schizoaffective disorder. And for anybody in the mental health field, that's sort of a combination of psychotic symptoms as well as mood symptoms. And they had been, you know, putting this person on a lot of medications and such. And as I started working with them, we started to realize that for periods in between, within the same day, this person was very cogent and collected and very intelligent, able to share their thoughts. And then there would be brief periods of time where they were not making sense, disorganized. You couldn't understand why their behavior changed so much. We started to say, well, this cannot be like a biologic schizoaffective disorder because you can't go in and out of it. And that's where we started to try and get this person's story more put together and realize that they had the most horrific type of trauma during their childhood. As you start hearing that story, you wonder, well, holy crap, anybody who went through that would have these problems. And there are some people who can be more resilient in some areas than others. But then we realized it's not a schizoaffective disorder. It's actually post-traumatic stress. And it's not just the DSM version of post-traumatic stress, but it's like times 10 or times 100. And no wonder people can't just recognize it and put their finger on it.
Right. So to that end, and for our listeners too, can you define what complex trauma is?
Complex trauma, when you look at the literature, has a lot of different definitions, but from a clinical picture, you're really looking at somebody who's had repeated significant traumas. And trauma we define as anything that overwhelms that person's capacity to cope. So it's not something that just hurts me or makes me sad, makes me upset, but it's that it overwhelms my psychological or biological capacity to cope with that thing.
Mm-hmm.
So these are often individuals who've had repeated layered traumas that can be considered small t's,
Mm-hmm.
but often in a way that it really makes them feel unsafe, makes it that they do not believe that they can actually work through
Mm-hmm.
this. And with that much fear building within the system and that much stress is where you start seeing complex trauma picture clinically, where people are not really able to function, can become very disorganized when memories of that trauma come up,
Mm-hmm.
but may have periods in between where they're doing really well and they could be very functional in one area, but then have other parts of their life where they're just falling apart. So just because somebody's a successful business person doesn't mean they can not also have complex
Mm-hmm.
trauma. And I think that's one of those myths where people think, well, once you have a mental illness, you're just non-functional. And if you're functional, then somehow you cannot also be unwell at that time.
Yeah.
Jasleen, I'm fortunate to call you a friend, and I've known you on the advisory board for some time now. And you always struck me as someone who is very interested. You're extremely interesting, but interested as well. I think you have a high level of empathy and you respond deeply and personally to other human stories, which I personally think is wonderful for a doctor. But as we know, not all doctors have that. And you talk about the threat of social inequality that resonated with you early. So you probably said, why is maybe one of your character strengths is fairness? So when you mentioned that, I immediately thought of our space,
Mm-hmm.
access to care.
Yep.
And I never worked in healthcare before. When you work in it, you realize how privatized this industry is, especially our former name, rehab path, rehab, right? The highest level of care, the most intense level of care for someone that is acutely ill. Now with Mental Health Parity Act, I just saw an awesome presentation from these guys who are doing great work in Kentucky. 95% of their clientele is Medicaid that are getting inpatient rehab for substance use disorder. Right, exactly. So to me, I don't have the depth of knowledge that you do. It seemed like this changed quickly with access to that level of care.
Mm-hmm.
Is that the Mental Health Parity Act? I'd love your thoughts on where it is today, what shifted, and where you think that's going.
Yeah, I think the Mental Health Parity Act was passed in 2008. And it took us really quite a while to get traction on that. I think equity, the funny thing and sort of like the naive part of me had thought when I moved from India to the US, that this being such a well-funded healthcare system, it would be beautiful. So imagine my surprise when I start training and I'm like, oh, there's people who are uninsured here. They don't get care. And it wasn't funny. Like it was very frustrating as somebody who was learning to realize that you wanted to do something for the patient. You knew exactly what was the good next step for them, and they couldn't get it. So I do think the enforcement of the Parity, Mental Health Parity and Addiction Equity Act that has started in the last few years is really good. I want to say maybe like 2018 onwards, so 10 years into the act actually being a federal law is when states started to recognize, or those of us who are advocates at the state level, started to realize that if we didn't do something in our state that made it that it was also the law of the land in your state, that there was no way to enforce it because a lot of the enforcement is actually at the state level. And so what we've seen over the last, 6-ish years is that various states have moved ahead and adopted some part of that federal act as part of their laws. Here in Arizona, we did that. We started the process in about 2018 and actually passed something called Jake's Law in 2020. And then, federally, there's been a couple other acts which are enforcement related, which we've also tried to over time enshrine in state laws. And so there has been that expansion of access as a result, or at least starting to question. And I think that part is right now still being worked out, like holding insurers accountable, making sure they're giving care. And in the Medicaid space, I think the Medicaid expansion that has occurred in the last 10 to 12 years in different states has definitely expanded what Medicaid provides. Here in the state of Arizona, we usually say that if you have Medicaid, you actually have a broader spectrum of services available to you, all the way from inpatient, residential, partial hospitalization, intensive outpatient. The partial is still sort of a little bit of a lacking space, but intensive outpatient. And then in outpatient, you get case management and peer support and like all these other layers, which if you have commercial insurance, you don't. Commercial insurance gives you outpatient, the various levels of care, but there's no wraparound. And often their standards are more stringent in some ways than Medicaid, or they're held to in a different way, which is why the various lawsuits we've seen too. But for me, equity is a core value. And so I think that's where the identity of being an advocate and feeling like I want to be the voice for people who either don't have a voice today or don't really know what to advocate for, and hopefully over time help others build their own voice so that they can go ask for what they need.
Yeah, I bet that was a rude awakening with this romantic vision of setting expectations unrealistically, like we got it perfect. I think I'm aligned with you that it just baffles me, and I hope it always does, that one human, never mind what country they're a resident of, can get access to healthcare that's different than another human.
Mhm.
Right. It just seems so bizarre, right? That
Yeah,
like that this person, because they have a net worth that is so different than this person's, can get access to care.
yeah.
It just seems so broken. We have a long way to go. Are you encouraged
Mhm.
with the progress?
I'm generally an optimistic person, and I would consider myself like an optimistic realist. So I do think we're headed in the right direction. Are we headed fast enough? No. Every day that somebody's suffering is not a good day. And I am also realistic in knowing that we're never going to eliminate human suffering, right? And so just working on the healthcare system may not be the answer. There's also the part about educating the public, right? Educating children, doing empathy training in school, being able to help people have more realistic expectations of the healthcare system. Something that I've been heard to sometimes I've been saying more recently is like sometimes people want their healthcare like they want their fast food.
Yeah.
It's like you want it right now and like 24/7. And that's maybe not realistic. Like if you have a sore throat, maybe that is not a crisis the same way as if you're acutely having thoughts about ending your life. And so when, in an ER setting, like I used to work in the ER and I have a lot of friends who work in the ER where people are ill treating healthcare staff because they think what their need is the highest level of need. That's very heartbreaking because healthcare professionals also have mental health needs. And being abused, yelled at, cursed at is just not acceptable. And I think as a culture, we have to some degree entitlement as part of some
No.
character trait. And we do need to start thinking like there are other people who are sicker than me. Am I really needing to be seen right now? And maybe not clog ER systems. Maybe go to the urgent care, or nowadays a lot of insurers are offering those like televisits with somebody who can just assess you for the sore throat. And so I think educating our public, educating people about where you should go for appropriate care is something we really need to do so that we're not stretching our healthcare system so thin. And then another piece, which totally different tangent, is like the pendulum has swung so far in terms of administrative burdens for healthcare professionals that there's a graph that we show often in healthcare conferences where the number of doctors has gone up barely, like maybe 10 times, but the number of administrators in health has gone up exponentially because the number of regulations, the number of forms you have to fill out, the different types of organizations you have to report to are so many that the amount of face time with a patient versus the administrative burden is very lopsided right now. In India, in a 8-hour shift, I could see 40 patients because my documentation burden was very minimal. And here in the US, you could maybe see 12 to 20 patients in that time frame. And that too, then you have pajama time at home where you're sitting and typing out your notes or like doing things. And so I think there's that part of equity too that we need to sort of start shifting back to say how much regulation is too much regulation.
Yeah.
Yeah.
Cliff, did you have anything else on that, or?
I have about 17 more questions I can ask, but Dr. Mala, I don't want to hijack, so I'll defer back to you. I'm going to save a couple.
Sure. Yeah, no, we started talking about complex trauma, and we'll get back to that. But since we're on the topic of equity, I loved the article Diversity and Inclusion in Psychiatry that you wrote. It was really exploring those cultural factors. And so my question to you is, in what ways do cultural factors like stigma around mental health influence that treatment and recovery process specifically for trauma? And how can clinicians navigate those complexities, especially when discussing, the things that you're talking about right now? Like, there's a lot that they're going through as well. One of the things that I'm also passionate about is providing support for providers. So I'd love to hear your thoughts on that as well.
Yeah. Culture is such a part of how we view the world, right? It's the lens that you wear through which you see the world. So I think understanding a patient's culture is an inherent part of doing a biopsychosocial evaluation in mental health, really understanding what is your association with this. So just before coming here, I was doing a ketamine appointment for an individual who I'd seen earlier this week for an appointment. And so I asked them as we started, I said, so how was it? Like, what is your association? And last week when they were starting, they told me, well, I know it's a drug. I know people abuse it. So I'm nervous about it. And they had heard somebody else in their group sort of talk about abuse. And now when I'm talking to them about the medication, I need to know with what lens they're looking at it, whether it's a placebo or a nocebo lens. And similarly with mental health treatment, like, do you have a positive association with it? Or are you judging yourself for being here in a mental health setting? I think that's one component of how our culture might influence how we're walking into any healthcare provider space. But then also there's the pieces around, how does my culture view suicide? How does my culture view people who are sick? What was talked about in my family about that? I used to do a lecture for our medical students, which was Intro to Culture and Psychiatry. And that's really what we would talk about. Like, what is culture? And I tell them, I'm like, culture is anything that influences your worldview. So if you're in a basketball cohort, then you also have a basketball culture. You're from a certain ethnicity, that's your culture. You're from a certain country or region, that also informs your culture. And so being able to understand a person's story, like you and I were talking about earlier, becomes that inherent piece to figure out, because we don't want to assume that just because I'm Indian, so yoga is going to be a big part of my recovery. Because I might not have a positive association with it. Or people assume that I'm Hindu because I'm from India and might not know that there's a record number of religions represented in the Indian population. So I think that's really where it's good to have awareness of culture, and we talk about people who talk about cultural competence, but really the piece that we're trying to work towards is cultural humility. We're trying to understand and let the patient teach us, and then utilize what their impressions are to either challenge or support as they go on their journey.
What would be your suggestion to patients or people who are contemplating entering into treatment of any kind, how they should explain their various cultures and how they should be forthright with that? Because sometimes there's difficulty with that, there's barriers to that, there's fear surrounding that. So what would your suggestions be?
I would start by saying that the onus really should be on the healthcare professional to make room for that. That's really our job, because there's a power dynamic when an individual walks into a clinician's office. So it really is us making it okay and making room for it. And as somebody who's seeking care, it is good to also reflect on what are things that influence how you interact with the medical system. Because a lot of people also have medical trauma. They've been in settings where they felt invalidated, not heard, not really felt like their wishes were respected. We're not trying to place blame here, because healthcare systems are also moving very fast sometimes, and there's unintended things that happen. But as a healthcare professional, me being able to recognize that, and then for the individual who's coming in, if they've been able to reflect on what are things that's important to them, because sometimes you've never thought about it. So if you're contemplating care, really think about, like, what are the things that are important to me? And they might change over time. I'm currently expecting my first child, and what I've realized is, like, people are asked to do birth plans, or at least they're given some sort of template by the office to say, do your birth plan. And different hospitals may follow your birth plan to different degrees, but at least consciously thinking through that makes you assess your options. And I think it's the same thing in any kind of healthcare. Sometimes we don't know that we're going to need healthcare, so we can't think about it. But that's what healthcare directive, or, those type of legal documents help you do, to say, if I was someday in an absolute medical crisis, what do I want done for me? My husband and I also have mental health power of attorneys for each other and medical power of attorneys. So that also made us very consciously have to sit down with each other and have a conversation about, if I get sick, this is what I want to do. And it was like talking through that process that helps maybe get a little bit clearer.
I love that. Yeah. I think oftentimes, it gets lost. People don't feel that they have the right, patients don't feel like they have the right to say, I'm going to let you, the provider, dig into this a little bit more, but I'm also going to allow myself to share, and so that reciprocity is important for sure.
I think there's some culturally relevant things here that I can contribute to both of you, my doctor friends. I come from blue collar working class people, and we were taught that there's a strong social class hierarchy that my dad really inherited, and he was poor. And we were taught that doctors were way up here, and they were smarter, and they were almost to be like revered, right? And now I know it can swing the other way, and everyone has access to WebMD now, so everyone has their own input. But I do think, Dr. Mala, right? Like, having a voice is wonderful, or having safe space to be able to ask a question. I'm fascinated with, like, and Jasleen, I'd love your thoughts on this. Why is it something that providers promote that is so wonderful, that they treat the whole person? Like, oh, you're not just going to take care of my elbow in a vacuum? Do you know what I mean?
Yeah.
Like, why do we have to say that? Does that make sense? Right? Because we're all so multifaceted and complex, and cultural influences, etc.
Yeah.
I didn't really understand. Oh, you want points because you're going to see me as a whole person. Does that make sense?
Yeah, 100%. And I think it's that same thing with the pendulum swing, right? Like that's just how the world operates. You swing one way, then you swing back. That historically, our cultures, all our cultural medicine, whether that's Native American medicine, kind of like my Indian, the East Indian medicine, you look at any of the other Mayan cultures, etc., you start to notice that back at that time, the shamans or the healers in the community actually saw all of you. It was physical, spiritual, like all those realms. But then when allopathic medicine started developing, it was more of a vocational training. And then as modern medicine has developed, we've moved in this direction of becoming more and more specialized. So it's like, oh, I take care of physical health. And previously, doctors would do all of it. So when you look at some of the prior philosophers and doctors of the time, usually it's like they were a medical doctor, philosopher, writer, artist, like they were these people who had multiple talents. But as we've become more and more specialized and focused and have very strict rules for training, we've moved in the super specialization era where now not only am I a doctor who treats the kidney, but maybe I treat a specific disease of the kidney. And so the super specialization has helped us really treat acute conditions well. But then what that has done is that we have divided people into little body parts. It's almost like because our doctors don't talk to each other, we sort of sometimes think that, oh, maybe our body parts don't talk to each other too.
Right.
Let's just treat the liver in separation from the lungs. And my hope is that, in the last 10 years or so, we've started seeing more integrative medicine. That's why the whole, like, I treat the whole person. We're an integrated health system, like we do mental health and physical health. And the hope is that we start moving our pendulum back a little bit, where people are coordinating more and realizing that if in a vacuum you're treating liver disease without really assessing what's driving the alcohol use, or if you're treating somebody for cancer but not treating the depression that comes with it, then you're going to have bad outcomes.
Right.
And that people are not going to be well. They might not be sick anymore. So right now we've moved in the direction of having a sick care system, and hopefully we'll start swinging back towards having a health care system.
Sure.
And it takes advocates on both sides of the aisle, the professionals, as well as people who are receiving care. Not that professionals don't receive care, but sort of like both sides of the aisle pushing together to say, this is not what we want. Thank you for giving me very specialized acute care. And we want our culture to become healthier and us to be considered as whole people everywhere.
Oh my gosh, yeah. Singing the song, like integrative care is something that I'm so passionate about. So how would you define the most ideal integrative situation and setting? I'd love to hear about that.
Yeah. And before I answer that question, I want to highlight that there's two different words that are used often. So there's integrated care, ED, and that is typically used for where mental health and physical health care are given together. And then there's integrative care, IVE, or people would call it holistic care, which is really considering physical, mental, but also sort of spiritual, cultural, that whole piece, and often bringing in ethnic or other cultural medicine in. The most ideal system, I think, obviously, is where the one primary care person who's at least taking care of you is able to have awareness of both the physical and mental components and is able to appreciate that you live within a social system that influences who you are, how you are, and that you have history that carries you.
Yeah.
But our primary care physicians, at least, are typically the lowest paid in the healthcare system out of all physicians and are very much overburdened. So we can't just leave it on them. And I think every single care provider or healthcare person does need to recognize that the person's problems didn't start the day their pain or their depression started, but that it is sort of their life story. And the more we can have communities that are cared for by people who live in those communities, the more likely it is that we can do that integrative.
Yeah.
And I think going back to the part about changing our culture, again, building community in the culture is such a big part because we have over time in the US become more and more isolated. So starting to figure out how to have more community, being able to go back to that type of setup may be nice. And it's hard to know how we'll get there.
Sure.
But I feel like in our niche areas, whenever we are with people, being authentic, being able to accept that I don't know everything, that I'm here to maybe guide you with the science I know, and allow you to teach me about who you are, how you like to live, where you want your life to go. That the more collaboration we can increase in the system, the more integrative and hopefully holistic and whole person centered we would get.
Yeah.
I think that I love how you're talking so much about the cultural relevance and the cultural impact. And I'm someone in long-term recovery, as both of you know, substance use disorder, alcohol, something that has really, really plagued my family, particularly on my father's side, and my community that I grew up in, where alcohol abuse was just so normalized. And I have to own it and have accountability, but I almost didn't have a chance about not being a hard drinker, and it's progressive and it finally caught up with me. But addiction, alcoholism, doctors, I believe, is in the DSM a serious mental illness, the same category as schizophrenia or bipolar. And I know that my poor mom was concerned that people knew that her son was an alcoholic. And I think almost even a concern like that changes our social class a little bit, right? All these things. And as an empath, I felt bad for my mom. Like that she had to deal with that. She's so open-minded, and I give her so much credit. She's amazing, and we've been so supportive, and we've done this recovery thing together. But Jasleen, so you said earlier, people come into the ER with some mental health related things, and they're saying, I'm not crazy. So I'd love your thoughts on someone in recovery from substance use disorder, which does have that classification. We know neuroplasticity occurs. It's a real thing. It's a wonderful thing. I will always struggle with addiction, but is that like the categorization of SMI? Does that change in long-term recovery? You know what I mean? Like, I think if you're schizophrenic, are you always schizophrenic? If you're bipolar, are you always bipolar? If you're a recovering addict, is it all the same? It's a complex question. I'd love your thoughts on it.
I try not to get on my soapboxes all the time, but I think,
Do it,
yeah,
please.
yeah, with all mental health disorders, there's a spectrum, right? Where everything's on a spectrum from what is considered normative and culturally acceptable. And I think, most people might not know, but the DSM is really built in the context of culture. It's about what is normative or out of norm for your culture a lot of the times. So especially, I think when we talk about severe mental illness, oftentimes it's an administrative designation in a lot of states. So people get like a SMI determination, which really is based on how much dysfunction the condition is causing you. And interestingly, even people with schizophrenia, which has that relapsing remitting pattern, where people can have symptoms of schizophrenia, which is psychoses for a while, and then they can settle out and then they come back. But what happens is that the more often you've had those psychotic episodes, the more likely it is that you'll have some sort of chronic presentation of schizophrenia. There are people with schizophrenia diagnoses who get treated very intensively up front and either have a milder version of the illness or, maybe got so well managed up front and typically a combination of the two that they continue to function. There's people who are PhDs who have schizophrenia, right? And have professions. There's similarly with bipolar disorder, which is considered one of those severe mental illnesses. There's forms, and with management, people can have really functional lives with periods of debility. And so I think alcohol use disorder or opiate use disorder, all of those are the same too. It really depends on how severe it got, how long chronically it was occurring, and how much debility you have. And that's really how you assess whether it's severely impacting your ability to function or not. And I think in a lot of disorders, I won't say all, but in a lot of disorders, you can start to, when you get treatment, you can start to move in the direction of more positive neuroplasticity where you're making your brain function better, developing more skills, able to have greater emotional regulation, and do sort of the things that feel functional in society. But with something like schizophrenia, part of the reason people think, oh, it's always going to be chronic is because a lot of the times it's caught a little bit late and it does have neurotoxicity built into the disease. That each time you have a psychotic episode, you actually, the psychosis is toxic to your brain cells. And so you lose cognitive capacity each time you have more of it. But we've also seen people with addictive disorders which don't get treated for a very long time, and maybe their baseline biologic psychological function isn't great because of trauma or other things, and they're not really able to recover their functional capacity. So I think the long answer, which I gave you, and then the short answer is for each of these conditions depends on how intense, how chronic, how long, and how quickly and intensively you got treatment, which is why I love the residential setting that I'm in currently, because I feel like we get to do intensive treatment and really help change the trajectory of somebody's life. Whereas a lot of the times with maybe more acute inpatient treatment or just outpatient treatment, you're either not being able to do something that's intensive enough, or sometimes you're not really able to spend the time to parse out what's really going on with somebody.
Yeah, a non-clinical friend of mine in long-term recovery, someone who's been a great influencer, role model for me, said, I have good news. Said this early. He said, your progressive state wasn't that long. So you have a fatal disease. And when you recover, you will end up being smarter and better off than you were before. What a wonderful gift this can be.
Yeah.
And I think that's true. I hope that's true. But that was a wonderful answer, right? Everything is on a spectrum. And there used to be terms like wet brain, right? So I think that there's damage sometimes if it is chronic over 15, 20 years that we cannot recover from certain things. So you just made me feel much better about me and many of my colleagues. Thank you so much.
Yeah, I'm glad. And I think your friend who shared their wise words with you, which I might be able to guess who that is, but we might not name them. And I think what they're really speaking about is post-traumatic growth, right?
Yeah.
That's the concept that sometimes when you're really having to go through something very hard, it might kickstart some level of resilience or some growth in you that you didn't know. And I even liken it to gardening for people who are into gardening. Like sometimes when a plant initially has to go through some sort of stress, that might actually make it that either it'll die, or very often, if it actually survives that stress, it's going to be a healthier, more resilient plant after that.
Bamboo.
Right? Like the more you cut it or the more you prune it, and that's why like pruning for plants is such a good thing, because you're trying to prune and really give them that right amount of stress. And so one of the ways that we think about trauma therapy or trauma recovery, or even raising resilient children, is that you want to give people enough stress, like some amount of stress, definitely. You don't want to remove all stress from a person's life. But then while they're in that stressed place, you also want to provide support. So it's that balance of pulling for them to be out of their comfort zone while providing support and saying, I'm here as your safety net, but go do this hard thing.
Yes. Yeah.
Because as you do hard things, you start to realize you can do hard things.
Right. Yeah.
And recovery is like the epitome of that. And recovery not only from substance use, but recovery from grief, recovery from depression, recovery from cancer. Like, I think Recovery.com is such a beautiful name because we're all in different stages of recovery from something.
Yeah, that's definitely really it. So you talk about intentional evolution. I'd love to have you share that with our listeners as well. Can you just take us through it? Take us through the definition and all of it.
Yeah. Intentional evolution is a term I came up with sometime in the early part of the pandemic, just seeing how many people were, going through sort of the chaos of life at that time. None of us knew what was going to happen. And I was actually in COVID quarantine at my house when this happened. So I told my husband, I said, I'm so bored. Can we at least, maybe get on camera or something and do some deep thinking about life and the world and such. And as we were talking, I said to him, I said, there's so many things in life we can't control. He's like, yeah. I said, and then as we were talking, we both started talking about, the thing that you can control at those times is how you're just reacting and showing up in the moment. And maybe sometimes not even in that split second when something difficult happens in your life, but choosing over the next 24 to 48 hours or the next week or the next month, what you're going to do with this really hard thing. And so I liken that term intentional evolution to sort of being in the driver's seat of your car. Like something may come and hit your windshield and you'll obviously be shocked and you can't be intentional in that moment of panic. But then right after that, you really do get to have a little bit of say in how you turn the wheel, where you stay. And so intentional evolution is my way of saying, no matter what life is throwing at you, if we can try and just be present, just think like, what would my best self do right now? Or what am I really trying to do just now, not in 10 years, not 6 months from now, but what is the best decision I can make today? That is a way that we can be maybe having a more intentional path in our lives, because change is the only constant. There's always going to be something new, difficult, different that's going to happen. And all we really need to do is focus on the decision in front of us and consider how we're continuing to evolve minute by minute. And we can take that approach to anything. We could take that approach to something difficult that happens in our life. We can take that approach to how we're going to be in our marriage. We can take that approach, in our workplace, and really trying to be present in the moment in your life, because that's the only time that you get to choose which fork in the road you're taking.
Beautiful. Absolutely. Thank you so much. So there's so much more that I had on slate for us to talk about today. But before we end, we're probably going to have to bring you back for a part 2. Before we end, the question that we ask everyone is, what does recovery mean to you?
Recovery to me means showing up every day in our lives and trying to do the best and the right thing that we can in that moment. Because I really do believe that we're all recovering from something, and being able to be present and take the next step is what we need to do. And we're all in recovery together from something or the other. So I think recovery also means being authentic and being supportive with each other.
Beautiful. Thank you so much. It was wonderful to talk to you, and we will have you back. We want to dive into those other topics that we initially talked about before we hopped on the call, but this is really, really great. So thank you so much.
Thank you for tuning in to today's episode of the Recovery.com podcast. For additional information, resources, and to access treatment options, please visit our website at Recovery.com. We appreciate your listenership and are excited to have you join us on our next show coming soon.